Welcome to 15 Minutes with. Today we have the pleasure to talk about vulnerable patient with Dr. Luigi Di Serafino, Interventional Cardiologist at Federico II University in Naples, Italy. Good afternoon, Dr. Di Serafino. Thank you for having accepted our invitation.
Thank you, Valentina. It's a pleasure for me to be here and to be invited for this interesting topic.
In the last years, one of the most progress in interventional cardiology is on cardiovascular imaging systems. Their use is linked to physiology of thrombosis, morphology of plaque, functional assessment of stenosis, because the intent is detect all lesions at high risk or potentially at high risk, which could cause new coronary events. All in all, one can say that to be looking for patient more vulnerable. So I will ask you first, who is the vulnerable patient?
Well, this is actually not just a question. This is the question. I would try to make it simple, and we had to say that the term cardiovascular vulnerable patient has been proposed to define subjects at higher risk for an active coronary event or a sudden cardiac death. This vulnerability is not only associated to the conventional cardiovascular risk factors, but it is also related to three main features, which are blood vulnerability, which means prone to thrombosis, myocardium vulnerability, which means prone to fatal arrhythmias, and plaque vulnerability, which means prone to rupture.
I see. It's really interesting. How to look for a vulnerable patient?
Well, actually, the ideal method for screening vulnerable patients should be inexpensive, relatively non-invasive, widely reproducible, really applicable to an asymptomatic population, and capable to increase the prediction value when combined with the conventional risk factors. So such a method should provide a cost-effective and a stepwise approach designed to further stratify the risk and provide reliable diagnosis and pathways for monitoring therapy. But despite significant advances in diagnostics ranging from blood testing to genetics, imaging, hemodynamics, the identification of patients and plaques at higher risk of adverse events remains limited. So the non-invasive imaging offers the potential as a screening tool to identify patients at increased cardiovascular risk before they present to the hospital for an ACS. While invasive imaging may further risk stratify patients who already present with symptomatic coronary artery disease or an ACS. So as observed in the original prospect study and other trials, angiographically mild vulnerable plaques that are likely to produce future heart cardiovascular events may be identified by intravascular imaging as those with large plaque burden, a well-formed necrotic core with high lipid content, a thin fibrous cap, and or a small minimal lumen area. So the risk, of course, increases when multiple seizures are present in the same stenosis. Currently, there is no indication to revascularize vulnerable plaques because most of them are angiographically mild and non-ischemic. However, progressive atherosclerosis and thrombosis of these lesions may result in an increasing frequency of angina, myocardial infarction, and cardiac death over time. Thereby, the identification of vulnerable features of residual coronary artery stenosis encourages clinicians to obtain a more rigid control of cardiovascular risk factors and a closer, why not a closer clinical follow-up.
Considering morphological investigation of coronary lesions with the NIRS plus IVUS, what are the benefits? Do we have clinical evidence of them?
Yes, as compared with the last 2 or 3 decades, we have a lot of tools able to morphologically assess coronary stenosis, including the IVUS, the OCT, and the NIRS. So each tool has, of course, several pros and cons, and the combination of one or more imaging modalities in one single catheter increases, of course, the efficacy of the tool, of both the tools. So in particular, the IVUS has a great spatial resolution, high tissue penetration, which allows to better morphologically assess a coronary stenosis. With IVUS, a large plaque burden and small lumen area and a positive remodeling have been shown to be a strong marker or markers of plaque vulnerability. However, the IVUS has only limited ability to identify the amount and the distribution of lipids present in a plaque. The NIRS, near infrared spectroscopy, which has been combined with the IVUS in a multimodal catheter, is quantitatively validated for the detection and for the characterization of plaque lipid content. So do we have clinical evidence? We have a lot of evidence. We have several trials which have demonstrated the value of NIRS in predicting MACE. The lipid-rich plaque study, for example, including 1,500 patients, more than 1,500 patients, demonstrated that deferred lipid-rich non-ischemic stenosis were associated with an increased risk of MACE at 24 months. In the recently published Prospect 2 study, the authors used the IVUS NIRS to get combined images of the 3 coronary vessels 1 month later the acute event, and after the treatment of all residual flow-limiting stenosis beyond, of course, the culprit stenosis. So in these high-risk settings, because of course they enrolled patients with the previous ACS, and after a median follow-up of 4 years, so the authors found that most of the events arose from untreated angiographically mild stenosis that were non-flow limiting at the time of the index event, and that the lesion most likely to cause a future event had a high lipid content and a large plaque burden, and in particular a lipid core burden index higher than or equal to 325, or a plaque burden higher than 70%, should be used to define a vulnerable plaque. So of note, plaques without these high-risk features have a very favorable prognosis over the next 4 years. So underlying the very high negative predictive value of this tool, which has, of course, an immediate clinical implication in providing reassurance of a favorable prognosis for the next 4 years for our patients. However, the positive predictive value of lesions with both a large plaque burden and high lipid content is still too low, but represents the foundation for future randomized trials.
So what is your experience in detection, management, and treatment of vulnerable patients with NIRS IVUS system? And what does it mean for an interventional cardiologist at a cath lab like yours if they want to implement it?
Yes, we currently use this tool to guide PCI in both stable patients and those presenting with an ACS. So while the data, the imaging coming from the high resolution IVUS can be used to guide PCI and to optimize the final result, NIRS can be, of course, used to assess the high risk potential of both stenosis undergoing PCI, maybe predicting the risk of the preprocedural myoccurrence, and of course, those stenosis which are deferred. So for the second question, what does it mean for interventional cardiology first of all, it is necessary a specific training before using this device. But the implementation, the everyday clinical practice in a medium high volume PCI center is particularly related to the operator's confidence with the tool and by the awareness of improving patients' clinical outcome when therapeutic and clinical decisions are guided by this new technology.
Good. It's really impressive and meaningful for modern patient management in every cath lab. Thank you, Dr. Di Serafino, for your precious time. We have appreciated that. Hope to meet you again for other news on cardiovascular imaging technologies. Goodbye.
Goodbye. Thanks a lot.